In the clinical clerkships, we presented an approach to acute kidney injury that follows the traditional teachings, like includes Athena. What this is going to be is the similar approach, right? I'm going to show you the advanced organizer that you're used to seeing, but then reveal how working up acute kidney injury actually goes in real life. So I liken working with the kidney to working with a stereo. So now you've got your outlet, the receiver with all your CDs in it. That's where Alexa lives. It's going to dial some controls. And you have your speaker. And you set it on the table. And you say, Alexa, play smooth jazz. Nothing happens. Looking on there, what's wrong? Yeah, plug it in. All right, machine turns on, good. Alexa, play smooth jazz. Nothing. What's next? Speaker. All right, you gotta make sure it's Wi-Fi connected. Look what you did there. You tested the power and the output. How many times have you opened up the receiver, gone looking for Alexa? Not very often, right? I liken that to how we're going to work up acute kidney injury. We're going to start with before the kidney, supplying the power, working with the output of the kidney, and very rarely looking into the kidney. So with that, you'll see this advanced organizer image that you're used to seeing. The heart is a pump, and it pumps through piping uphill to imply that there's some resistance there, delivers blood to the kidney. The kidney does something magic, and out the other side, the output comes urine. Ureters to the bladder and urethra. A couple things could go wrong. The heart could break. We could have loss of fluid from the pipes, or there could be third spacing of that fluid. This was CHF, being volume deplete, dehydration, diarrhea, diuresis, and hemorrhage. And this was represented by the oci, in particular cirrhosis, but also from any albumin-reducing process, nephrosis, and possibly from malnutrition, gastrosis. But in reality, being intravascularly deplete while being volume up is more likely going to be CHF and cirrhosis. And then this advanced organizer also accommodated for blockages of the renal artery, which was renal artery stenosis and fibromuscular dysplasia. Regardless, this is pre-kidney, which equals poor perfusion. CHF is overload, but poor perfusion. Cirrhosis is total body up, but intravascularly deplete. Being volume down is being depleted. And renal artery stenosis and fibromuscular dysplasia is a special case. These are put up there because these are the challenges you're going to have to deal with pre-renal. If they're CHF, they're overloaded. If they're overloaded, what are you going to do? Diurese. If they're obviously volume down, they're volume deplete. What are you going to do? Give them volume. Cirrhosis. Ooh, it's a tough one. You may give diuretics or you may give albumin. It depends. But you can see how different now our approach has been from the core lectures. We jump over to pre, we're at pre, now we're going to post, jump over to post. Post is about obstruction. And if you obstruct the outflow of urine from the stretchy ureter, but the kidney keeps making urine, it's going to distend. The marker of obstructive uropathy is hydroureter and hydronephrosis. Obstructions can occur at various levels. Stones and cancer can be at any. Both genders can suffer from neurogenic bladder, cord injuries, or even medications for spastic bladder, and men can suffer from prostate issues, usually BPH. We checked the power source, we checked the output, and you do need to know a little bit about the intrinsic, but you see it can be glomerulonephritis, acute interstitial nephritis, acute tubular necrosis, nephrotic syndrome, nephritic syndrome, etc. If you need to go looking for Alexa inside the receiver, you should call for help. So if you can't figure it out from 1 and 2, you're going to need nephrology. And if you need nephrology, get them the things that they want. Don't call them for them to tell you, hey, you consulted us, we need these things. Right? You're going to get a renal function panel, which is a BMP that has a phosphorus and an albumin. Just get a CMP if you want. You're going to get a urinalysis with urine micro. You're going to get a urine creatinine, even though you know the FeNA is not worth anything. We'll cover that in a second. And you also want to get the urine lights. Sodium, potassium, chloride, and a spot protein. You don't have to interpret that, but you do need to get it. All right, so this looked like I was trailing off. Yes. How do we as internists actually approach an elevated creatinine? The first thing I do is I look and say, all right, are there obvious pre-renal causes? Do I have the diagnosis? Is acute kidney injury part of a syndrome that they already are displaying? If they are volume up, such as in heart failure, I diurese. If they are volume down, as in overt sepsis, I give volume. At the same time, I ask myself, could this be post-renal? I don't wait for the results of that. You're looking for a history of neurogenic bladder, spinal trauma, look at their medications. And if it's there, act. So you can either act by doing an ultrasound and waiting to find if you've got hydro, or you could just throw in a Foley. Right? Now, point of care ultrasound, check out to see if they've got a big distended bladder. I wouldn't try the ureters or kidneys yourself though, but you can just put in a Foley. And so if you have hydro or a large volume diuresis right after the insertion of that catheter, you know that the obstruction is now relieved and it was obstructed. The ultrasound I still get anyway, even if there is a large void. I want to know what the hydrostatus is of the ureters and the kidneys. And if it's not any of that, and I think it's intrarenal disease, even if I know that it's ATN and I can manage that, call in renal with my panel. Ureters. If the problem is at the level of bladder or prostate, a Foley catheter placed into the bladder will drain everything. Large volume diuresis, white blood cells may follow. If you have hydro and you need to relieve the obstruction, surgery needs to come in and cut it to place in a nephrostomy tube, which is why you need to have both the Foley placed and the ultrasound done. This is urology, this is a nurse. So this changes the perspective from the clerkship years to beginning of internship. When someone presents with acute kidney injury, what you want to do is actually find their diagnosis, because acute kidney injury is probably a symptom of a syndrome. And if you can make the diagnosis and treat the syndrome, the kidneys will get better. That's my approach to acute kidney injury.